Dear friends, good evening and warm greetings. IPS AP State Branch invite you all for today's webinar on the occasion of World Alzheimer's Day on 21st September. It's a great opportunity for all of us to utilize this occasion for creating awareness among public and to have academic activities for our medical fraternity on Alzheimer's disease. We profusely thank our distinguished guest, Dr. K. Chandrasekhar, for accepting our invitation to speak on early diagnosis and management of dementias. You all know Dr. K. Chandrasekhar is one of the senior most psychiatrists in both the Telugu states. He is the authoritative on dementias as he has been working on it for the last 4 decades. He has established a proactive neuro-rehabilitation center in Hyderabad. Now I request our CME chairperson, Dr. G.V. Raman Rao Garu, for his brief remarks, followed by Dr. Narasimha Reddy Garu to chair this session. Thank you.
Thank you, sir. Thank you very much. Dear colleagues, all of us know that India is aging and naturally the problem of dementia is on the rise. In our day-to-day practice, we see lots of patients with forgetfulness coming to us. And we have certain difficulties sometimes. Is it really a dementia or is it a minimal cognitive impairment? Or is it a treatable dementia? Or is it a pseudo dementia? So many doubts we'll get. I'm sure Dr. Chandrasekhar, who is an expert in this field of dementia across the country, he will enlighten us about the assessment of, for people coming with forgetfulness and other cognitive problems. And he will also share with us his expertise in the management of early dementia. Without much ado, I request our chairperson, Dr. Narasimha Reddy Garu, proceed. Thank you very much.
Thank you, Dr. Raman Rao and Dr. Ivan Narasimha Garu and Dr. Chandrasekhar, today's main guest speaker. I think all of us are aware that World Alzheimer's Day is being celebrated on 21st of September every year. And we call this September month as the Alzheimer's month. I think most of us know dementia is something different from the Alzheimer's disease. Dementia is a term which describes certain clinical features, whereas this Alzheimer's disease is a specific disease with features of dementia. So if you look at the various prevalence aspects of dementia and Alzheimer's disease, so in case of dementia, nearly 60 to 80% of the dementias belong to the category of the Alzheimer's disease. So this was realized a long time back. I think some of you are aware of this Alzheimer's Day International, Alzheimer's Disease International, Alzheimer's Disease International. This is an organization which was established somewhere in 1984. And in the 10th celebrations, in the 10th anniversary celebrations of Alzheimer's Disease International in Edinburgh, they have started this celebration of Alzheimer's Day. So the first Alzheimer's Day was celebrated on 21st of September 1994. So that was the first Alzheimer's Day International was celebrated. I think if you look at the people suffering from dementia, the magnitude of the illness is very high. I think one can say for every 3 seconds, one dementia case is adding on to the population. So that is the quickness with which the dementia is progressing nowadays. And the other important thing which all of us should remember is, so the prevalence of dementia definitely goes higher and higher over a period of time. This is absolutely related to the elderly age. I think we all know people who aged 65 and above are increasing in population. So if you look at the Indian statistics also, for example, just like any other country in the world, the elderly population is increasing. So currently it is somewhere around 7%. The elderly population constitutes about 7% in the general population existing in India. And by 2030, 35, I think people are expecting it's going to be increasing more and more. And sometime in the near future, I think it goes up to 14%. So when the elderly population is getting increased, naturally, we expect the dementias, the prevalence of dementias also gets increased. So naturally, we need to take care of. So if the dementias are increasing, that itself indicates, so the more and more number of Alzheimer's disease patients gets increased. So there is every need for all of us to create a lot of awareness in the public regarding the nature of the dementias, the early signs and symptoms of dementia. And if necessary, there are some warning signs that we are going to get related to the Alzheimer's dementia. And early intervention, early diagnosis, early intervention, and naturally, we must be able to prevent. So this is the main aspect of this Alzheimer's Day celebrations. So basing on this, there are so many Alzheimer's societies existing in throughout the world. So this Alzheimer's Day International is associated with nearly more than 100 centers in the world. I think we ourselves in India also have started this Alzheimer's Day Internationals in Kerala in the beginning. And they're also running somewhere after 1996 and all that. So a lot of importance has been given to this Alzheimer's disease, its early diagnosis. So the earlier we make a diagnosis, the earlier we'll be able to take control over the disease that is going to occur, and we can try to prevent it. We can try to identify the risk factors as early as possible, including the necessary changes which we are supposed to do in the lifestyle changes to prevent the occurrence of dementias in general. Dementias includes so many other dementias, as Dr. G.V. Ramandar has already pointed out. Not only Alzheimer's dementia, we have several other categories wherein we can definitely take some precautions in controlling some of these risk factors. So with this introduction, I invite our senior colleague, Dr. K. Chandrasekhar. I think most of you have heard about he giving several lectures in the, geriatric psychiatry. I think he is a popular figure, and he has done a lot of studies on this dementias and all that. I request Dr. Chandrasekhar Garu to please proceed with his presentation. Thank you.
Thank you, sir. Dr. IVL Narasimha, President, Indian Psychiatric Society, Andhra Pradesh chapter, and the other executive of IPS AP chapter, the CME committee chairman, Dr. G.V. Ramandar, Dr. and other members, Dr. Vishal and Dr. Ranjit Kumar, and chairperson, Professor Narasimha Reddy Garu. It's indeed a pleasant opportunity for me to see all of you go on webinar. Anyway, in the next month we'll be meeting in person and talk to you or share my thoughts on Alzheimer's disorder on the eve of World Alzheimer's Day. Let me just share my slides and I'll go ahead with the talk. Is it visible?
Yes, sir. Yes, sir. It's visible.
Yes, sir. Yes, sir. It's
Very
visible.
much visible.
Oh. See, even few years ago, everyone used to think that Alzheimer's disorder is an exclusion diagnosis. you exclude almost all the causes of memory problems and behavioral problems, and then come to a diagnosis of dementia, and that's it. And always it was thought that the final diagnosis is only through autopsy. And this sort of a thinking was held for a long time. However, in the last 10-15 years, there are several advances which made Alzheimer's dementia as a definitive diagnosis. And the challenge is how soon we can really detect it and start the needed intervention. If you look at the prevalence of dementia worldwide, almost in 2015, it was around 30 millions, but gradually it is increasing. Almost it doubles every 20 years in one sense. So somewhere we are now between 2020 and 2025. So somewhere the low middle income and middle income countries witness almost about 40 million people. And right now it is estimated that there are about 55 million people suffering from Alzheimer's dementia worldwide. And with this sort of a increase in the incidence of this particular disorder, I think what exactly we are doing to see that the suffering of these people will be less. If you come to India, again, somewhere right now we have about almost about 6 million people suffering with dementia. And all of us know that the services or the necessary infrastructure for catering to the needs of this population is almost very meager. One thing which all of us have to remember is Alzheimer's dementia is a neurodegenerative disease. It's a disease. A lot of times it is mistaken to be a problem of old age, not only by the general public, but also by majority of the doctors. The common refrain is, anyway, he is becoming old, so he has to have some sort of a memory problem. As we all know, it's not only the memory, it is the behavior which gets affected in Alzheimer's. So we have to recognize it as a disease, and it is a neurodegenerative disease. In the DSM-5 classification, it is classified as a major neurocognitive disorder. Though there are various types of dementias, Alzheimer's dementia is the largest subgroup, accounting to almost 60 to 80% of all dementia patients. The other segment includes the Lewy body dementia, vascular dementia, frontotemporal dementia, etc. The epsilon 4 allele of APOE gene is a strong genetic risk factor. Carriage of one E4 allele speeds up symptomatic onset of Alzheimer's disease by 10 years. Though the genetic component, the cases which have a large genetic component is much less. It's only about 10 to 15%, and rest of them don't have a basic genetic component. So this is the extent of the problem we are having, and how do we go about doing an early diagnosis for this sort of a problem. If you look at the basic definition of the Alzheimer's dementia, it's a progressive neurodegenerative disease associated with cognitive, functional, and behavioral impairments, and characterized by two pathological hallmarks, basically progressive accumulation of amyloid, beta plaques, and intracellular neurofibrillary tangles. This is the hallmark pathology in Alzheimer's dementia. And how soon we can detect that this pathology is existing in the brain? That is the basic question. Now there is what is called as a Alzheimer's disease staging. There is a preclinical disease phase where it is supposed to be the earliest stage. It is much more, maybe a couple of decades before actually one sees the symptoms manifesting. At this stage, there are no clinical symptoms, but there is evidence of changes in brain pathology, such as the buildup of hallmark proteins, amyloid, and tau. So, if the patient of the person is manifesting symptoms of dementia, say at the age of 65 or 70 years, probably there was the accumulation or buildup of these two hallmark pathological features somewhere about when he was around 40 years or even 35 years. The next is mild cognitive impairment, commonly known as MCI, where there are subtle changes in cognitive abilities, which may be evident to very close people who are associated with the individual. But these symptoms are not severe enough, and it doesn't produce a major difficulty in the day-to-day conduct of that individual. Usually, the mild cognitive impairment stage may last about 3 to 4 years, and then it can pass on to the stage of mild dementia, then later to moderate dementia, to severe dementia. So the whole process of dementia progression occurs over a period of 3 to 9 years, or sometimes even more. I've got patients who are there for more 12 years or 13 years after the diagnosis. So this is how of course, there are different ways of nomenclature. The National Association of Aging, NAA, and AA classification is there. Alzheimer's Association classification. There is another was International Working Group is also there. So, but ultimately, the essence of the thing is there is a preclinical phase, there is a mild cognitive phase, there is mild dementia phase, moderate dementia, and severe dementia. What is this preclinical AD? It is a long asymptomatic phase, as I told you earlier, maybe anywhere between 15 to even 20 years. There is evidence of AD pathology, Alzheimer's disease pathology in the brain. There is no evidence of cognitive or functional decline. The risk of progression from preclinical AD to MCI to Alzheimer's disease depends on various factors like age, the common risk factors, or like hypertension, diabetes, head injuries. These are sometimes known as risk factors, but also the ApoE status and the family history of dementia. So the risk of progression increases from there. It is not that every person who has had some pathology in the preclinical phase goes on to develop Alzheimer's disease. Only 20 to 30% with AD pathology will go on to develop MCI or Alzheimer's dementia. This was seen in studies which followed up for about 4 years. I think if the follow-up is much longer, probably one may tend to see more number of cases converting into MCI or AD dementia. But as of now, whatever the literature says is the conversion rate could be only about 30%. Now coming to MCI phase. In the MCI, minimal cognitive impairment is manifested by the individual struggling to find the right words. He tries to speak, but suddenly you forget the right word, what exactly to say. And the individual also forgets recent conversations, like what he talked yesterday or in the morning or a couple of days earlier, forgets recent conversations with friends, family members. So this is what we call as an episodic memory disturbance. They struggle with completing the familiar tasks, the executive functions problem. Tasks which he was doing it day in and day out for the last several years. Suddenly he finds it very difficult to execute it totally. And sometimes he gets lost in familiar surroundings in terms of visual-spatial disturbances. The minimal cognitive impairment can be amnesic or non-amnesic. what we mean by non-amnestic is only the language disturbances can be there, visual-spatial disturbances can be there, the memory will be slightly be normal. And the individual is relatively independent despite potential marginal deficits in function. So in lot of times, if you remember, or if you really observe the people around us, when a person with this sort of a problem comes often to a family physician, or even sometimes any doctor or a family member, the immediate refrain is that you're getting old, so naturally it is but natural to have these problems. Actually, this is the stage where we have to be very careful and see that this individual's needs are addressed properly, the diagnosis is made properly, and see that the conversion to MCI to dementia gets delayed as much as possible. The individual with MCI is relatively independent despite the potential marginal deficits in function. So there is not much of a dependence on the family or friends or in general for carrying out his routine functions. He has varying coping mechanisms and levels of cognitive reserve. So in spite of this minor sort of a difficulties, he carries on with his life. Conversion to dementia in 3 to 4 years, usually maybe different studies put different figures, but anyway, it can stretch from 40 to 70%. And this is actually the phase of dementia, wherein there is a significant cognitive impairment in one or more domains of attention, executive functions, learning, memory, language, perceptual motor abilities, social cognition. And herein, the cognitive deficits start interfering with independent functioning in daily activities. And depending upon the type of interventions, the type of environment in which the individual is placed, the rapidity with which this dementia passes on from the mild stage to severe stage depends upon various factors, as I said earlier. You see the portrait of an artist, a famous artist, Italian artist, whose self-portrait, if you see 1996 to 2000, in 4 years, how his perceptual abilities and his skills have deteriorated. So in 4 to 5 years, sometimes you see the skills of the individual deteriorating very rapidly. So how do we do an early diagnosis? This can be divided into 4 steps. One is detect. Step 2 is assess and differentiate. Step 3 is diagnose. Step 4 is treat. Early diagnosis is the step 1. So when any individual presents to a doctor with minor problems, or sometimes it's also the duty of the family physician or the primary care physician to inquire into the cognitive history in the patients when he comes with any complaint, if the patient is an elderly person. Sometimes the caregiver's perspective is very important. Medical and disease history is very necessary. And this is what happens in an early diagnosis. What are the symptoms associated with suspected early stage of Alzheimer's disease? One can look into the areas of cognition, behavior, psychological, and physical, and general functions. If you look at the cognitive aspect of in a very early stage, we find the short-term memory loss, word finding difficulties, or communication difficulties. A lot of times we concentrate only on the memory. It is not the memory, it is the language also we have to focus on. A lot of times these word finding difficulties give us a clue that probably something is amiss. Because the individual at that time has got definite insight into his problems, he tries to withdraw from the social activities. He becomes aloof. Uh, he starts having incapacity to participate or inability to participate in meaningful social situations. Sometimes there can be inappropriate social conduct or a poor or decreased judgment. These are the things which the individual notices, and sometimes he becomes very withdrawn and even moody, which leads to psychological changes like depression, mood disturbance, and apathy. And the family also notice that there is a changes in mood or personality of the individual, and from a feeling of helplessness, a loss of purpose in life, and loss of initiation. Most of us as psychiatrists know this. Sometimes we diagnose it as depression and continue to treat it as depression alone without going into the possibility of a dementia. I think this is where, as psychiatrists, we have to be very careful. A lot of times, elderly people who present one with depression or some minor behavioral disturbances can end up having probably the early dementia. Then physical activities that because of visuospatial problems, sometimes there can be imbalance, there can be gait impairment, and the person may be having frequent falls. Sleep disorders occur, and the patient's sleep rhythms changes. Sometimes rapid eye movement disorders, such as acting out dreams and all these things, can be seen in very early stages. So this is where probably one has to be careful in eliciting the history. And what are the things which routinely, probably a primary care physician, or even if otherwise any doctor who sees an elderly patient with these sort of problems has to really inquire into? One thing is, has the patient had any recent illnesses? What happens is sometimes, especially respiratory infections, urinary tract infections, any infective pathology for that matter, sometimes decreases the cognitive reserve, and the patient may manifest almost with a picture of dementia. A lot of times I've come across patients being diagnosed in the medical wards as dementia because he is unable to recognize his relatives, is unable to say the recent events, and it's very easy to confuse that with a picture of dementia because the cognitive reserve decreases because of any illness in the elderly. Other thing is, as a patient uses any medication that recently that could cause memory loss, especially high dose benzodiazepines or anticholinergic drugs, or sometimes even opioid group of drugs. All these things, when the individual is taking, there may be a possibility of individual complaining of memory problems, or like illicit drugs like opioid drugs. Other thing is there a history of epilepsy. Sometimes it happens that the patient's the seizures are not under control, or the individual gets subclinical seizures. Probably there may be apparent apparent decrease in the cognitive functions. And one has to also inquire into what are the risk factors. Is there a history of dementia within the family? Does the patient have any other medical conditions such as cardiovascular disease or obesity? Is the patient a smoker or ex-smoker? Then cognitive behavioral changes. What does the typical day look like for the patient? The history can be taken from the patient or a close relative. Has the patient noticed they are forgetting things or misplacing items recently? Has the patient noticed any changes to their mood or felt helpless recently? Has the patient had any issues with finances, unable to operate his bank account, unable to give the proper change or proper financial transactions? Has the patient had any falls recently, which I was illustrating some time ago? Has the patient noticed any issues with the balance? Does the patient have any vision or hearing problems? Is there anything else the patient or caregiver is concerned about? These are all the things which will help us to come to an early diagnosis. Step 2 is assess and differentiate. So once you suspect there is a cognitive disturbance, how do you go about it? At the primary care level itself, some of these things can be done, like a blood count, thyroid profile, blood glucose, serum B12, liver and renal function tests. This can be done at a primary care levels. Genotyping probably, I will come to it at a later time, probably not immediately. The neurologic examination, a thorough neurological examination to rule out probably other neurological things which can present with cognitive problems. The thorough physical examination to rule out other comorbidities, this is an essential thing. Cognitive assessments, one should be able to do a detailed cognitive assessment depending upon the extent of the cognitive dysfunction. MMSE sometimes may give you not full information, so one has to have something which he is familiar with. In most of the places in India and at our place also, we use Addenbrooke's cognitive examination, which gives a fairly good score or reasonably good understanding of what are all the factors which can be affected in dementia. So to have a cognitive assessment, usually an MMSE coupled with ACE, that is Addenbrooke's cognitive examination, will be always be a useful method to assess. So we have to use a structured thing to know about the extent of cognitive deficit. A lot of times the routine mental states examination sometimes may not get the correct idea of to what extent the cognitive deficits are present. The functional, like instrumental activities of daily life, then the various other scales are there. Whichever the clinician is familiar with, he can employ that. And for the behavioral manifestations, to know the behavioral changes, one has to do or have at least a geriatric depression scale and also the neuropsychiatric inventory, which gives us some idea of what are the various behavioral and psychological problems which the patient might be manifesting with even at the early stages. If we have sufficient information, the two imaging things which are very essential at this stage is MRI and FTC PET. Let me just give a brief account of what this imaging need is about and how we should get it done at the earliest. The imaging tests can identify the subjects with a high risk of developing AD while at the MCA stage with a meaningful accuracy. This is what we have to understand. Structural imaging provides information about the shape, position, or volume of brain tissue. Structural techniques include magnetic resonance imaging and computed tomography. Now we have functional imaging, which reveals how well cells in various brain regions are working by showing how actively the cells use sugar or oxygen. We have molecular imaging, which I'll come to it a bit. So structural imaging is very commonly done in a routine clinical setup. That is MRI, we get it done. Compared to CT, MRI is always preferable. We get a more clear idea of the different regions which are affected because of Alzheimer's. The shrinkage in specific brain regions, such as the hippocampus, may be an early sign of Alzheimer's. Of course, we have to correlate these MRI findings with our clinical examination and the structured clinical examination, which includes cognitive functions. The structural imaging is currently used to define pre-existing tissue damage associated with neurodegeneration and to rule out other conditions that may cause symptoms similar to Alzheimer's but require different treatment. So MRI helps in other ways that we rule out some of the treatable causes like even NPH or infections or any other thing which probably is causing the cognitive dysfunction. Structural imaging such as MRI can reveal tumors, evidence of small or large strokes, damage from severe head trauma, or a buildup of fluid in the brain. Like I said, sometimes NPH. Now, functional imaging. This again generally done. Alzheimer's patients have reduced brain cell activity in certain regions. Studies with fluorodeoxyglucose, FDG, PET, indicate that Alzheimer's is often associated with reduced use of glucose in brain areas important in memory, learning, and problem solving. So FDG PET scan is considered a reasonable test for people with a recent diagnosis of dementia and documented cognitive decline of at least 6 months who meet diagnostic criteria for dementia. So in a routine clinical workup, when the individual comes with probable MCI, it is always better to get, along with the blood tests, the structural imaging like MRI and a PET. This will give us enough clue to us which and confirm MCI so that at a later stage we can guide the patient in a proper way. Coming to the molecular imaging, it is also uses PET scans to diagnose Alzheimer's in its earlier stages. Molecular strategies may detect biological clues indicating Alzheimer's much before there is any structural or functional deficit. So it helps us to know the pathology much earlier. Molecular imaging also may offer a new strategy to monitor disease progression and assess the effectiveness of next generation disease modifying treatments. So several molecular imaging compounds are there nowadays. The most familiar one for us is the Pittsburgh compound, but later there are several other compounds which have come for molecular imaging. This is a PET scan of a Pittsburgh compound where we see that the PET brain scan on the left is of a Alzheimer's patient, right is from a healthy adult. Red areas in the Alzheimer's patient show the greatest levels of amyloid. The dark blue indicates no amyloid. So this is how we can differentiate the extent of amyloid plaques. So this is a mild Alzheimer's disease only. So you can, even in MCI, if there is amyloid plaques or there, even in the preclinical phase, probably these things will be much apparent. There is another genetic profiling. There are 3 genes with rare variations that cause Alzheimer's. There are several genes that can increase the risk but don't guarantee the person will develop the disease. As more effective treatments are developed, genetic profiling may become a valuable risk assessment tool for wider use. The genetics testing for ApoE4, the strongest risk gene for Alzheimer's disease. However, as of now, because we don't have any preemptive treatments, it is not recommended routinely. Other important thing nowadays for diagnosing very early is the biomarkers. Of that, the CSF biomarkers gained a lot of importance in the last 3-4 years. So the core markers are amyloid beta CSF, which includes amyloid beta 42 and the A beta 42 and A beta 40 ratio, the tau CSF, p tau and t tau, and PET imaging. These are the 3 core markers nowadays, though there are exploratory markers. Plasma assays, they are not yet standardized, but probably very shortly they may also become more standardized, and then the we can probably detect at earlier stage without doing a lumbar puncture. So the routinely used biomarkers are beta amyloid A beta 42, CSF A beta 42 levels are significantly reduced in Alzheimer's disease patients due to its increased deposition in amyloid plaques. So the CSF levels of this A beta 42 are very low. In MCI, CSF A beta 42 compared to t tau and p tau is the most accurate biomarker that will convert to AD. So if you have clinically detected MCI and if you have a biomarker like A beta 42, then probably you can predict that this person may be or will definitely go into dementia. Total tau protein is a basic element of neurofibrillary tangles and located mainly in the neuroaxons, dendrites, and cell bodies. CSF t-tau shows the extent of neuronal damage and neurodegeneration in AD. Increased levels of t-tau is observed in MCI and AD. This can be detected from very early stages of AD and is stable as time goes by. Further, it has a great sensitivity and specificity in the differential diagnosis of AD from normal aging. So you have a MCI patient, you have confused between the normal aging forgetfulness or it's probable MCI leading to AD, then you get this test done, then there is 93% of specificity and sensitivity and specificity. As all of you know, anything beyond 80% is taken as a good test. T-tau levels is also increased in other neurodegenerative diseases like various tauopathies, including FTD, progressive supranuclear palsy, corticobasal degeneration, and also in ischemic stroke and trauma. Compared to T-tau, it's the p-tau which is more specific. The phosphorylated T protein or p-tau is higher in AD, and discrimination is more accurate with p-tau than T-tau. See, increase in p-tau levels and reduction in A-beta 42 levels is correlated with volume loss in hippocampus. Usually, the combination of biomarkers helps us a lot in detecting MCI and also which is going on to develop AD. So, combination of CSF, A-beta 42, T-tau and p-tau levels has 95% sensitivity. Suppose if you see the abnormality in all the three things, then there is 95% sensitivity and 83% specificity determining the patients that will develop AD. So you have an MCI patient and you determine these levels and you know whether this patient is going to AD or not. The low CSF A-beta 42 and high tau levels combined with medial temporal atrophy are associated with increased risk of MCI conversion to AD. So the take-home point is that these CSF biomarkers are very useful in trying to predict from how the person from MCI might go into definite dementia. The biomarker ratios helps in predicting future MCI and dementia in a cognitively normal older adults. And as I said, CSF and MRI markers give 91.8% accuracy for diagnosis of AD. So CSF biomarkers can be used in routine clinical practice in distinguishing AD from normal as well as other types of dementia. This is an important point. Now there is enough evidence showing Alzheimer's disease CSF biomarkers are reliable, reproducible, and valid. So without doing an autopsy, without doing any microscopic examination after the death, we are convinced now that there is a definitive diagnosis which can be made with reference to Alzheimer's disorder. The National Institute of Aging and Alzheimer's Association and International Working Group, in the revised criteria now, they include CSF AD biomarkers in clinical diagnostic workup. Having all the three biomarkers in normal range rules out AD. Suppose in a MCI, you get or possible some sort of a memory deficit or cognitive deficits you are seeing, or it may be having a problem with distinguishing between age-associated memory loss or early MCI. Then if you have all the three biomarkers in normal range, you can rule out AD because the pathological changes would start 20 years earlier. So there is no question of not finding these biomarkers. It's very valuable in cases where clinical diagnostic workup is not able to discriminate between Alzheimer's disease and non-Alzheimer's disease type of dementias. So these biomarkers are not abnormal in other types of dementias. So it gives us a fair idea of the differential diagnosis. So what is evidence-based clinical indications for application of ADC as a biomarker panel? One is early onset dementia. Definitely one has to get these things done. Ambiguous clinical diagnosis, you are not able to make a proper clinical diagnosis, you are doubtful. A preclinical AD is only for research. Right now, for consent, people who give consent, it is only of a research sort of an interest if you want to do these biomarkers in the preclinical AD. That means you don't know whether the person has got AD or not. But sometimes the family members, sometimes they may ask, someone in the family has got dementia, and whether there is a possibility of me getting the dementia. But however, it is not recommended because right now we don't have anything to offer in terms of treatment once you detect that there is a possibility of dementia. So that is the reason why there is a caution here that we should not advise to people who do not have any symptoms. When there is a prodromal AD or MCI, clinical evidence for cognitive decline definitely is there, then probably it is worthwhile doing CSF biomarker studies. Differential diagnosis for dementia, Alzheimer's dementia versus non-Alzheimer's dementias, Alzheimer's dementia versus vascular dementia, then probably it is worth doing. Undiagnosed of atypical AD variants. Sometimes you have atypical frontal variants of even AD, and also what we call as a posterior cortical atrophy variant, or sometimes you can have what we call the logopenic Alzheimer's disorder, wherein it's an atypical manifestations, but it's Alzheimer's disorder. So this is where we can get these biomarkers done. So once you make an early diagnosis, what is the treatment which you are going to advocate? The rationale for early diagnosis itself is, as I said, addressing very safety issues to minimize hazards from driving, cooking, and over medication for individuals staying at home, reduction of caregiver stress via early education about the disease, service available, and how to handle patients' needs. Specific treatments that are available work best when started early in the course of illness. So before we start the treatment, it is the how you communicate your diagnosis. The communicating diagnosis basically is very important in case of once you make the diagnostic communication should not happen in one sitting. One has to look into it. It should be something like a family counseling session, and one has to take care how to tell them the possibility of this person's deteriorating over a period of time, what are the precautions they have to take, how to go about handling this at the earliest stages. So it needs to be a sort of a diagnosis sharing, and this communication is a very important first step when you are trying to communicate the diagnosis with the patient. So once the diagnosis is confirmed, you do a post-diagnostic support. Unfortunately, in most of our clinics, most of our work, we see not many MCIs, but we see more of early dementias. So already the dementia has started, but probably there are some clinics, memory clinics, if there are spread over a vast area, probably one may get more and more MCIs. One thing which we have to desist from doing is stereotyping dementia. As soon as dementia is diagnosed, one should not feel that is a burdensome disorder, it's a hopeless disorder. It is not worth our time and energy. This is what majority of us sometimes try to convey. Anyway, there is no treatment now much. The individual is going to suffer like this. So you have to cope up with the situation. And with this, generally, we dismiss the family. The most significant roadblock regarding the dementia care and management after diagnosis is the absence of a prescription of care for what may lie ahead. A dementia diagnosis often leaves the individual and their family carers devoid of information, specifically about how it may progress and how to manage its related everyday challenges. That is the reason why I said diagnosis should be communicated, discussed over a period of time, maybe 3 or 4 sessions, rather than prescribing an initial round of medication, which may or may not help symptoms. The medical community, most of us, does not always provide crucial educational material, nor does it refer to support services in the community. So generally, once the diagnosis is made, we prescribe some medication, and we know half-heartedly that it may really, whether it helps or not, we are ourselves are not very sure. So we have to do in the management a semi-structured functional assessments, which I already mentioned. So what is the pharmacological agents which we have for cognitive enhancement? Donepezil which is a cholinesterase inhibitor. Then we have galantamine, we have memantine, and we have rivaroxaban. These are the most 4 commonly prescribed drugs, so that there is a increase in acetylcholine levels. The memory deterioration is little bit slowed down. The progress is slowed down, so the patient's activities of daily life can be continued. It has been several studies have shown that without any medication, the deterioration is much faster, but with some sort of a medication, cognitive enhancement, deterioration takes a lesser decline. The latest aducanumab, disease-modifying immunotherapy, prescribed to treat mild cognitive impairment or mild Alzheimer's. That removes abnormal beta amyloid to help reduce the number of plaques in the brain. The lecanemab is a humanized monoclonal antibody. Both the things, both these medications are given intravenously over a period of time. I think monthly once injections, IV infusions over a period of 6 to 7 months, so that there is improvement. But there are a lot of question marks around the usage of these drugs. There is exorbitant cost, and also the real utility or usefulness, how much of this is really questionable, but still they are the approved drugs by FDA. As of January 25, 2022, there are about 143 agents in 172 clinical trials for AD. The pipeline includes 31 agents in 47 trials in phase 3. That means phase 3 trials, 82 agents in 94 trials in phase 2, and 30 agents in 31 trials in phase 1. Remember, the disease-modifying therapies represent almost 80% of the total number of agents in trials. So nowadays, the emphasis is on disease modification, not trying to give some medicine to improve the memory after dementia has started, which majority of the drug therapies found that there is not much of a use. So we have to prevent the amyloid plaques formation. We have to prevent the neurofibrillary tangles. So how to modify this disease? That is the main emphasis nowadays for the various pharmacological agents being tried. And 83% of these drug trials are centered around this. For symptomatic cognitive enhancing, there are only 9% of the agents in trials. And drugs for the treatment of neuropsychiatric symptoms, 6.9%. Management of BPSD, I don't want to go into details because it's an informed audience. All of you know any of these, the status of the patient we use. One thing which all of us have to remember is that unlike the routine psychiatric disorders where we use the medications for 6 months, 1 year, or so, depending upon the nature of the illness, the depression or schizophrenia or psychosis or bipolar disorder, whatever it is. In the BPSD in dementias keep changing over a period of time, even within few weeks to days. So never medicate them continuously. Try to revise the medication. We use the very minimal dose, and try to revise the medication even if every 2 weeks or 3 weeks. My own experience is that with a lot of environmental manipulation, which I'm going to talk in a couple of minutes, the amount of antipsychotics or antidepressants or anxiolytics or even hypnotics needed can be minimized to a large extent. A lot of times, the side effects of this medication itself will further cause problems for already a decompensated cognitive individual. Then the question of non-pharmacological interventions, there are 2 aspects to it. One is targeting the carers, one is targeting the persons with dementia. Targeting the carers is through various meetings, carers meetings held either once in a month at least, where you discuss the various aspects of the disease, the problems they are facing. The which generate through these meetings are sometimes very useful. One family which has managed a particular behavior, they try to tell the other family, this is the one way of doing it. So there is a lot of supportive talk which happens in these caregivers meetings. Another important thing is the activity center, where mild to moderate dementias can spend their time. As you know, it depends upon the stage of the disease. It depends upon the areas of the brain affected. See, BPSD is not random events. The BPSD symptoms occur because of specific pathologies in specific areas of the brain. So different people manifest different symptoms and react differently to the situations. So in daycare activity, we can really monitor such sort of a behavior and see what can be done. This is again an activity center where people are engaged. This is a reminiscence therapy where the individual looks into the old photographs, tries to recollect about that individual, narrate a story centered around the individual. Reminiscence therapies are done, and cognitive exercises are implemented, and some sort of a skilled activities are trying to do. So implementing the care is basically a collaborative care model. It is not a clinic-based or hospital-based care. It has to occur in a community in a primary care setting. A collaborative care in a primary care framework will give the desired results, and it can reduce the burden on the healthcare system. Managing the person with dementia is not in the domain of any single specialist, and a multidisciplinary team is required whose advice and expertise needs to be coordinated and implemented by the primary care physician. So every time the patient has got a problem, we need not run to the specialist. We have to coordinate with the primary care physician or the family physician how to manage these intermittent irritants which occur to the individual and how to make him more functional at its home. So the continuity of care is the need of the hour for dementias. So it should be a home visit, home care, and where there is a lot of gradual deterioration, probably respite and long-term stay may be beneficial. Sometimes the family wants some sort of a respite. The carer gets exhausted. So for a short time, maybe a month or two, the patient can stay in a respite home, and then probably the family can get rejuvenated and take the patient back. Or if the patient is continuously being almost bedridden, probably he may need a palliative care facility. So in conclusion, let me say that we are going to witness a surge in cases of dementia in the coming years. There is no escape from this. In the coming years, diagnosis is going to be much more precise and early, as we discussed extensively a few minutes ago about the CSF biomarkers. And if the plasma biomarkers also come into play, then probably it is much more easier. More therapeutic advances will occur in near future. They are in the pipeline. Currently, the available services are sparse, and we have to prepare ourselves to meet the future challenges. We require models of care which are practical and sustainable. We need skilled staff, partnership with carers, facilities for assessment, early identification, and post-diagnostic support. A person-centered, individualized care plan executed by integrated care teams in dementia-friendly environment is the need of the hour. The picture you see on the left is our respite care center, where we have now around 40 plus persons with dementia at different stages. And thank you very much for giving me an opportunity to share my thoughts on dementia on the eve of World Alzheimer's Day. Thank you very much.
Thank you, sir. Thank you. Thank you very much for your excellent presentation. I think we have learned a lot from you. Why? Because I think, especially as far as the diagnostic aspects are concerned, I think we are definitely advancing. I think, as you rightly pointed out, not only the blood-based biomarkers tests like AD detect and estimation of CSF T tau and P tau and their significance in eliminating the diagnosis of the Alzheimer's disease when compared to the other disorders. I think they all give us a very good comprehensive knowledge about early identification of the disorder as such, and also to exclude the other non-Alzheimer's dementias. That's one thing. Even treatment aspects also, I think you have covered a lot, and you have clearly told about the drugs which we routinely use as far as the drugs that treats the cognitive symptoms, the drugs that are available for behavioral and psychological symptoms of dementia, and the other therapies, the coming therapies targeting this amyloid beta. I think we have already told about the two important drugs, that's aducanumab and lecanemab. I think these are the two molecules I think already given FDA approval last year, and some people are already I think using in US and all that. Of course, with some limited experience and with some warning signs related to the therapies as such. They are mostly the infusion therapies with a lot of side effect profile also, as far as these two drugs are concerned. The other thing I just want to talk to you about this Alzheimer's vaccine. I think most hurriedly in the recent past, I think FDA has already given what do we call it as the fast track designation to an active immunotherapy vaccine that specifically target the most toxic form of the amyloid beta, that is A beta, amyloid beta. I think even that also, if the vaccine really comes into existence and easily available at a price which is affordable for many of the individuals, I think we need to select the people who are more vulnerable for developing Alzheimer's dementia in future. I think that we must be able to identify and then go for the vaccine and all. I think you have some idea about that vaccine. Now I think it's open for discussion. I request the audience to interact with the speaker and then get the clarifications.
Question, Dr. Chandrasekhar. Sir, what would be the approach for behavioral and psychological symptoms of dementia due to other medical conditions, like, for example, NASH, non-alcoholic steatohepatitis? Because sometimes we get such patients, and we don't know whether these drugs what we're using really act for them, like our donepezil, or for behavioral symptoms like our quetiapine. What is your experience, sir?
I mean, along with some comorbidities you are
Yeah,
asking.
dementia due
patient
to other medical conditions, like dementia due to NASH or dementia due to maybe chronic kidney disease. In such conditions, can these drugs be tried? Because the real problem, because even the so-called other specialists also, they refer to the psychiatrist.
See, basically, the pathophysiology of non-AD dementia is different from AD. That's one thing. However, because there are not many cognitive enhancers, people try to use the same donepezil or rivastigmine. In fact, rivastigmine is one drug which is more recommended in such comorbid medical when the patient's dementia may not be Alzheimer's but has got cognitive impairments. The reason is rivastigmine also can decrease the delirious effects, especially in medical conditions. So that is an additional property which rivastigmine has got. Apart from that, there routine behavioral management is done. As in cases with behavioral manifestations, I still use a very, very small dose of haloperidol. If the patient is very agitated, nothing like that. Haloperidol drops. I use haloperidol drops, just 2 to 3 drops. They calm down, they don't get sedated. The problem with some of other psychotropic drugs is that they become extremely sedated. Even risperidone can cause severe sedation. Sometimes some individuals, where there is already some sort of a decreased cognitive reserve and when they have various other medical comorbidities. I still use haloperidol drops in divided doses, and the agitation and the restlessness comes down a lot. Once they are stabilized, then we look into a lot of times there is the other causes which increase their agitation. Some pain somewhere which they are not able to express. Sometimes some even severe constipation, impacted feces, things like these things. Once we for the clinician to examine the patient, at least use a scope. Once you give haloperidol drops, they settle down, and one can proceed further with the diagnostic work. That's how I go about it.
Sir, you're absolutely
Thank
right,
you,
sir.
sir.
You're absolutely right, because of almost all the antipsychotics, we have a black box warning in the dementia, in uses of in case of dementia with its behavioral symptoms. But still, we do come across a very good improvement with maybe some 0.25 or not even 0.125 milligrams of haloperidol in divided doses will definitely calm down the agitation which the patients experience, and even the relatives get worried mostly about it, because most of the times they disturb the relatives like anything. So in such cases, I think we have to. I think in the recent days, sometimes we are preferring even among the antipsychotics. I think aripiprazole in low doses, maybe less than 2 milligrams in the night time. So like that, I think, and in some cases where there is some excitement, especially in the dementias, Alzheimer's disease. Sometimes we go for a mood stabilizer. A mood stabilizers like divalproic sodium or sodium valproate, maybe somewhere around 400 to 500 milligrams. Even they are also comes to be very useful in controlling that aggressive behaviors, which most of the relatives may not be able to tolerate. That's about it.
The important thing is, I think in PPSD is environmental manipulation.
Yes.
That is the crux more than the medicines. See, as I said, in the respite care center which we run, the dosage of the medication is very, very low.
Yeah.
Rarely we give an SOS medication. Never I get a call saying the patient is disturbed in the night. If he's not sleeping, the attender who is looking after him will take him out for a small walk like in the corridor,
That's a very
and gets back to the sleep. So environmental manipulation is the key there.
very important, sir. Very important. Very important. If the patients are taken out, I think most of the patients, they get relaxed. We see a dramatic change in the patient's behavior and their cooperation with the relatives. We do come across.
Question answers in the chat box. I
Yeah,
think there are
any
some
question?
questions.
Subrut, Subrut.
Sir, good evening, sir. Sir, my question is regarding the role of blood thinners, sir, in management of multi-infarct dementia or any dementia per se.
The blood thinner sometimes can be even a risky thing. A lot of times elderly people we see bleeding in the brain. The more blood thinners are used. So one has to be very cautious as far as the blood thinners are used in this population. We can sometimes see subdural hematomas when with a slight fall, they may sustain an injury and the bleeding may not stop. A lot of times this is noticed, or even gastric bleeding. So one has to be very careful unless absolutely indicated.
Yeah.
I don't think that's a good idea to use blood thinners in this population.
Unless there is a clear-cut indication of some cardiovascular disease, I think it's always better to avoid this type of blood thinners.
For minor injury, sometimes they get a bleed in the brain.
Yeah.
In a subdural or intracerebral, sometimes it can happen.
Sir, we have a couple of questions in question answer chat box, sir. Metformin, role of metformin, lithium, omega-3, fluoxetine, any help? When to prescribe levodopa for dementia frontotemporal?
See, for dementia, several drugs are used, but none of them are really proved efficacious. Starting from curcumin to everything under the sun, people give it. So there is no scientific or evidence for this. But What is the drug was asked?
Omega,
Omega-3 fatty acid.
omega 3
Levodopa has no role. Levodopa has no role in frontotemporal dementia. The only drug which has got some role, which is prescribed, is SSRI. In frontotemporal dementia, one can try using SSRI, especially fluoxetine. Levodopa has got no role in FTD.
Is there any mind diet?
Pardon?
Mind diet.
Mind?
mind diet.
Diet.
Diet. This is what I said. People recommend several things. Even omega fatty acids or dietary restrictions, dietary supplements. A lot of dietary supplements are advocated, but everything has got its own advantage. It's more of a subjective sort of a feeling with the family says, okay, we have been giving this, the patient is better. But there are no scientific evidence for any of these things.
Chandrasekhar, how do we manage the common problem noticed by the attendants that they sleep during daytime and awake in the nights? How do you manage it?
The reversal of sleep rhythm anyway in dementias. Is the reason why, as far as possible, avoiding daytime sleep episodes. Try to take them out. That is one thing. Difficult. The second thing is we give melatonin much earlier in the day. Give around 5 o'clock, about 10 milligrams of melatonin. It starts acting somewhere around 8:30 or 9 in the night. And then add zolpidem at 10 o'clock. The initiation and sleep both are taken care of in majority of the individuals. That is a practice I do, and it gives some results. Definitely.
Sir, one more question, sir. Rivastigmine is used for dementia and Parkinson's disease.
That's what I'm saying. See, any cognitive enhancers can be used. Maybe rivastigmine or donepezil, but Parkinson's dementia is again advanced Parkinson's. You get dementia, then you have to use some cognitive enhancers for whatever the role they have.
Thank you, sir. One more question, sir. Is diagnostic biomarker profile available currently? If so, where it is available?
It is available. NIMHANS has got it, but they're not doing it as a routine. They do it for research purposes. But even if the routine someone asks, I think they might do it, but the results come they say not immediately. They take 2-3 months because they do it in batches.
Yes,
The Abbott and Roche have got abroad, but I am sure if one can inquire from Abbott or Roche, they may be able to tell whether they have brought those kits to India.
Right.
Some of the corporate hospitals, I don't know whether they are doing it, but Abbott and Roche are the two things which sell the kits in abroad in USA.
Yes, sir. I think they're costing somewhere around $400 or something.
No.
Sir, one more question. Uday, sir.
May I, sir?
Yes, sir. Yes, sir.
Yes, please. Please.
Audible. No. First of all, thanking state AP state branch to bring the right person onto the board to say about Alzheimer's. Sir, Chandrasekhar sir, thank you very much for very
you, Uday.
lucid, informative lecture, sir. Am I audible, sir?
Yeah,
Yes,
you're audible. You're
yes,
audible.
we are.
Yes, sir. Yes, sir. In this connection, I would like to ask you one question, sir. Are there any prospective studies in India, say MCI to dementia, dementia to vegetative state, how long they would take in usual independence, and what are the real factors would cause to jump up to MCI to dementia to vegetative state? So if we can do that kind of prospective study, which is very useful, so that we can really understand and prevent to happen the dementia, at least fast happening of dementia, sir. That is one. And second one is the gold standard treatment for dementia standing now is psychosocial management of dementia, sir. I don't think there are any good number of medication which would really proving now to say that this is anti-dementia drug. So two things, sir. Please, I take your call, sir.
So regarding prospective studies, because you need a very large cohort to really come to those conclusions, it has to be a multi-center study. I think NIMHANS has got some registry which they are doing it. But I think most of the places where there are dementia clinics or memory clinics have to pull up their data. I don't think at one place one can do such a thing, because there is a tendency, the follow-up is important.
Yeah.
See,
Should be for long
unless you
years.
have home visits, once you have a team who follows up the case, very often they get lost. That is one reason. So it has to be multi-centered, very dedicated sort of a teams working in memory clinics, which is possibility. I don't know. I think NIMHANS would be working on that. The second thing is regarding the psychosocial management. As of now, yes, you're absolutely right. That is the way. That is the reason why there are a lot of encouragement for home teams, home visit teams, palliative care, or things like that, where psychosocial factors are taken in importance.
Yes, yeah, thank you, sir. Thank you.
Thank you, sir. Thank you, sir. Ranjit.
Sir.
Thanks, by Ranjit.
I would like to thank.
Just
conclude చేద్దాం.
yeah. I think we had a nice discussion also. I think Dr. Chandrasekhar has cleared out so many doubts of the audience, and so finally, what we would think in this aspect of Alzheimer's Day celebrations and all that, we should always try to concentrate more on early diagnosis. That's early diagnosis is very, very important, and we must be able to find out the risk factors that usually lead on to the Alzheimer's disease. And knowing about the Alzheimer's disease and creating awareness in the public about the various aspects that are importantly related to the Alzheimer's dementia as such. And we can advocate even the important aspects like changes in the lifestyle, the regular lifestyle changes. We can always give them the suggestions related to why can't we make alcohol abstinence, cut down the smoking, and some simple issues like continuous learning, learning enthusiasm. That definitely plays to some extent an early important part in preventing the disorder. So the other things like social interaction in the elderly age, even that was also found to be very important in postponing or preventing the early onset of this Alzheimer's disease. So advocating the lifestyle changes, identifying the various symptoms of the Alzheimer's disease, dementia at an early stage will definitely go a long way in managing these individuals effectively. So thank you very much for giving me this opportunity, Dr. Ivel Garu, Dr. Sarath, and the entire IPS AP State Branch, and all the other people, and all the people who have joined this program in the night. And I thank Dr. K. Chandrasekhar profusely for dealing with the topic in very extensively. I think he has shared his wisdom to all of us. Thank you, sir. Thank you, one and all.
Thank you very much.
Thanks, Ranjit.
I would like to thank Dr. K. Chandrasekhar Garu for his excellent presentation and eye-opening presentation. I would also like to thank Dr. Narasimha Reddy Garu for chairing this session so wonderfully. He showed the direction, like how a session must be chaired. I would like to thank the CME committee members, Dr. J.V. Raman Rao Garu and Dr. Indla Vishal Garu, for talking about this program. I would like to thank the President and Secretary, Dr. I.V.L. Narasimha Rao Garu and Dr. Sharath Chandra Garu, for constant encouragement for these academic activities. And finally, the Crescent Pharma for sponsoring this program. Thank you everyone for participating in this program.